Assalamu alaikum. Hello, my dear student. How are you all? I am Dr. Muhammad Ruhul Amin, welcoming you all on my online class. As you all know, today we are going to discuss about chronic liver disease on the basis of your board questions. I think it will be very effective for you all. Chronic liver disease. I have an advice for you all. Stay safe, stay connected, stay always with your books, and stay with our online classes. Chronic liver disease. In your final professional examination, you have lots of problems regarding chronic liver diseases. Whenever you will face your final board, a clinical scenario may be given to you on the basis of chronic liver disease, and you have to identify it. You have to formulate a differential diagnosis on the basis of chronic liver disease. And you have to evaluate the patient on the basis of your clinical scenario. On the other hand, in your written examination, there are lots of questions are given regarding the chronic liver disease, and no doubt about this matter that in your long case, many of your students will face chronic liver disease case. So I think we should go through in this way that whenever we face a case of chronic liver disease, we can answer all the questions asked by our examiner. So before that, objectives of our today's class are understanding the basic mechanism of complications of cirrhosis, getting an idea on the management of these complications. Yes, these are two photographs. I think that both of these photographs detailing patients of chronic liver disease. Here, abdominal swelling, cachexia, here jaundice, cachexia 2. A case scenario. This kind of case scenario may be given to your final professional examination in your board. A 52 years male patient was admitted like that of anywhere. Anorexia and abdominal swelling for 2 months, vomiting of blood and passage of black thigh stool for 2 days and unconscious for 4 hours. On examination, GCS was 12/15. He was anemic. Ecteric. Flanks were full and distended. Distended abdomen with presence of collateral vessels over anterior abdominal wall and along with stigmata of chronic liver diseases like spider nevi, leukonychia and gynecomastia. He had flapping tremors. So first you have to formulate a differential diagnosis or 2 to 3 differential diagnosis, and you have to evaluate on the basis of these kind of clinical scenarios. So what could be the provision diagnosis? Yes, very clear. Chronic liver disease with portal hypertension with incapacity, encephalopathy, etc. Main thing is that chronic liver disease. Now we have a discussion on chronic liver disease. Chronic liver disease is defined as a liver injury occurring over more than 6 months. Cirrhosis is a condition that is defined histopathologically as the end stage of chronic liver disease. Cirrhosis is defined by three characteristics: bridging fibrous septa, parenchymal nodules, disruption of the architecture of the entire liver. So in your final professional examination, you may ask a question that what is cirrhosis or what is chronic liver disease? You have to define it meticulously. And definitely after that you will be asked what are the causes of cirrhosis, what are the causes of chronic liver disease. You have to know some causes. Definitely chronic viral hepatitis like hepatitis B, C, alcoholism, non-alcoholic steatohepatitis, immune mediated like autoimmune hepatitis, primary sclerosing cholangitis, autoimmune cholangiopathy. Biliary causes are primary biliary cholangitis or cirrhosis, cystic fibrosis, hemochromatosis, alpha-1 antitrypsin deficiency, Wilson disease. All of three important genetic causes. Wilson disease. If a patient comes to you with cirrhosis in younger age, this is a case of Wilson disease. Alpha-1 antideficiency, liver disease with lung disease combined with, and hemochromatosis is, as you all know, iron deposition in the lung. Cryptogenic unknown causes. Complication: portal hypertension, spontaneous bacterial peritonitis, hepatic encephalopathy, hepatocellular carcinoma, hepatorenal syndrome, hepatopulmonary syndrome. So whenever the examiner will ask you the causes of cirrhosis, after that he will definitely ask you some complication of cirrhosis, at least portal hypertension, spontaneous bacterial peritonitis, and hepatic encephalopathy. You have to say, if possible, hepatocellular carcinoma, hepatopulmonary, hepatorenal syndrome, and hepatopulmonary syndrome. If it is possible for you to say, you will answer or not. Portopulmonary hypertension, malnutrition, coagulopathy, bone disease, hematological abnormalities, and endocrine abnormalities. Another question may be asked to you: what is the cause of coagulopathy in case of chronic liver disease? Because as we know, liver is a factory of synthesizing various type of clotting factors. So in case of a chronic liver disease, liver is not able to synthesize this kind of a clotting factor, so coagulopathy may ensue. In case of portal hypertension, there may be gastroesophageal varices, portal hypertensive gastropathy, splenomegaly, hypersplenism, and ascites. Another question is asked frequently that a patient come to you with distended abdomen, edema, distended veins on abdomen, and on your clinical examination you found splenomegaly and ascites. What may be your clinical diagnosis? So the answer will be chronic liver disease with portal hypertension, as there is splenomegaly and ascites. So you have to answer this question very meticulously. This kind of question is asked very frequently in your final professional examination. Portal hypertension is defined as the elevation of the hepatic venous pressure gradient to more than 5 mm mercury. Cirrhosis is the most common causes of portal hypertension in the United States, and clinically significant portal hypertension is present in more than 60% patients with cirrhosis. So whenever we will find a patient of cirrhosis, we have to think development of portal hypertension. If there are splenomegaly, ascites, and other stigmata of CLD, we have to think that portal hypertension has developed. The signs of cirrhosis results from portal venous congestion and collateral vessel formation. Splenomegaly is a cardinal finding. Visible collateral vessels in the anterior abdominal wall, ascites, gastroesophageal variceal bleeding, rectal variceal bleeding, rarely caput medusa. All of these things are the signs or complications of portal hypertension. Gastroesophageal varices, one of the very important causes of gastroesophageal varices is chronic liver disease. When we will find a patient of chronic liver disease, we have to screen for gastroesophageal varices. So a question is asked, frequently asked to you, causes of hematemesis in case of cirrhosis. What are the causes of hematemesis in case of cirrhosis? Look, acute gastric erosions. Lots of other causes, but one of the most important causes is acute gastric erosions. Endoscopic view of a esophageal varices. Treatment, primary prophylaxis and prevention of rebleeding. So, in case of gastroesophageal varices, what type what type of treatment may be given? You may ask this question. You will simply just answer that we have to maintain primary prophylaxis and prevention rebleeding. Primary prophylaxis requires routine screening by endoscopy of all patients with cirrhosis. It can be achieved through non-selective beta blocker, propranolol or nadolol. And just examiner will ask you that just name one drug by which we can prevent gastroesophageal reflex varices, or in which you can use a name a single drug you can use in your esophageal varices treatment. Just answer propranolol or nadolol, beta blocker. Other measures are endoscopic variceal ligation, and in case of acute variceal bleeding, treatment are immediate fluid replacement and blood transfusion. Then to prevent for further bleeding accomplished with repeated variceal band ligation. We have to reduce the portal venous pressure with the help of vasoconstricting agents like terlipressin, octreotide. You have to know the name of the two drugs, terlipressin and octreotide. Transjugular intrahepatic photosystemic shunt surgery. You have to know just know the name of this procedure. And what are the how we can prevent recurrent bleeding, repeated variceal band ligation until varices are obliterated, beta blockers, photosystemic shunt surgery, and tips. Ascites is one of the very important topics regarding your chronic liver disease. Ascites. Ascites is the accumulation of excess amount of free fluid within the peritoneal cavity. So, examiner may ask you question: what are the causes of ascites? You have to tell 3 to 4 causes of ascites, keeping your mind in CLD. Look, the most common causes of ascites is portal hypertension related to cirrhosis. Ascites is the most common complication of cirrhosis. Normal amount of fluid in the peritoneal cavity 30 to 50 milliliter. Ascites with no clinical symptoms but may be detected in ultrasonography more than 100 ml. If there are more than 100 ml fluids present in peritoneal cavity, ultrasonography can detect it. Fluid trill and shifted dullness present when more than 1 liter fluid is present in peritoneal cavity. So here we have to know this amount of fluid. This question may be asked to you. Pathogenesis, portal hypertension, splenic vasodilation, decrease effective circulatory volume, and activation of renin-angiotensin-aldosterone system. So renal sodium activity, sodium avidity, renal sodium, renal will keep sodium avidly, and there will be development of ascites. On the other hand, renal vasoconstriction, hepatorenal syndrome will develop. So what are the clinical features of ascites? An increase in abdominal girth, swelling of feet and face. If massive shortness of breath, hepatic hydrothorax may also occur, contributing to respiratory system symptoms, which is more common on the right side and implicates a recent in the diaphragm with free flow of ascitic fluid into the thoracic cavity. However, swelling of feet and face and abdominal girth is most important. Signs of ascites. Shifting dullness may be present without distension. Remember, shifting dullness may present without distension. Abdomen distended with flanks full, umbilicus evated, and transverse slit with shifting dullness. Whenever you will face a long case, you have to, if your case is chronically what is, you have to find this kind of finding. Abdominal distension, flank full, umbilicus evated, and transverse slit with shifting dullness and shifting dullness. And fluid thrill. Distended abdomen, flanks full with fluid thrill. Tense, distended abdomen, fluid thrill, but no shifted dullness. If there are tense, distended abdomen, fluid thrill may be found, but no shifting dullness. And there are grading of ascites. How can we diagnose with the help of our investigation? Ultrasound or CT scanning, ascitic fluid study, determination of total protein and albumin content, blood cell count with differentials, cultures, amylase cytology. If cause ascites cause due to pancreatitis, acute pancreatitis, amylase may be increased, and there will be blood cell count have to perform because there are concomitant infection. And protein and albumin content have to perform to identify the ascitic fluid is exudative or transudative. And in patient with cirrhosis, an ascitic fluid protein concentration is less than 2.5 gram deciliter. So if please remember this figure. Serum ascites to albumin gradient SAG subtraction between the serum albumin level and the ascitic fluid albumin level. If it is more than 1.1 gram per deciliter, then the cause of the ascites is most likely due to portal hypertension. This is most often in the settings of cirrhosis. Please remember this. Examiner may ask a question to you there. What is serum ascites to albumin gradient? Say treatment. Small amount of ascites, dietary sodium restriction, On the right amount of ascites, diuretic therapy, initially spironolactone and furosemide may be given. If there are refractory ascites, refractory can be defined as non-diuretic response with spironolactone 400 mg per day and furosemide 160 mg per day. Spironolactone and furosemide, if you apply this kind of doses but there is no response, it is refractory ascites. So a question may be asked to you, what is a refractory ascites? You should answer this. And treatment modalities include repeated large volume paracentesis, TIFs and peritoneal venous shunt. Prognosis is poor. You may consider for liver transplantation in patients with those onset of ascites. Some patients will have a fairly significant left-sided and left upper quadrant abdominal pain. And in physically we can find an enlarged spleen. Usually no treatment record. What is hypersplenism? This question is frequently asked to you. What is hypersplenism? Hypersplenism with the development of anemia, neutropenia, and thrombocytopenia is a common feature of patients with cirrhosis and is usually the first indication of portal hypertension. So, what is hypersplenism? You have to describe it. So, hypersplenism is a complication of chronic liver disease. Even a question may be asked to you if a chronic liver disease patient comes to you with stroke. What will be the cause? You can answer various way. One of the causes is this thrombocytopenia. Congestive gastropathy or portal hypertensive gastropathy occurs in long-standing portal hypertension. Spontaneous bacterial peritonitis. You find a patient, a CLD patient with fever, abdominal pain, and other septicemic feature. What may be the cause? Cause may be spontaneous bacterial peritonitis. Common and severe complication is of ascites characterized by spontaneous infection of ascitic fluid without an intra-abdominal source. In patient with cirrhosis and ascites severe enough for hospitalization, spontaneous bacterial peritonitis can occur in up to 30% of individuals and can have a 25% in hospital mortality rate. So it is very important. We have to keep our mind regarding development of spontaneous bacterial peritonitis. It's a very grave condition for CLD patient. Pathogenesis of SBP, bacterial translocation with guard flora traversing the intestine into mesenteric lymph nodes. Bacteremia, seeding of the ascitic fluid. The most common organisms are Escherichia coli along with Streptococcus viridans, Staphylococcus aureus and Streptococcus species. Clinical features: fever, abdominal pain, rebound tenderness, increasing ascites, absent bowel sound, and so on. Investigation: absolute neutrophil count and CBC, white cell count, may be elevated. Treatment: antibiotic with second-generation cefatoxime or ceftriaxone. Administration of norfloxacin or ciprofloxacin is used as prophylaxis for recurrent SBP. Hepatic encephalopathy or portosystemic encephalopathy, hepatic precoma. It is very important regarding the CLD patient. It is one of the very grave complications of CLD. Defined as an alteration in mental status and cognitive function occurring in the presence of liver failure. Pathogenesis and due to the gut-derived neurotoxins, ammonia, gamma-aminobutyric acid, and mercaptans, octapamine, amino acids, and fatty acid. When all of these neurotoxins are accumulated in the body, they will transfer into the brain and cause hepatic encephalopathy. Please remember the name of these things. Clinical features: changes of intellectual, personality and consciousness, apathy, some convulsions. Precipitating factors very much important: hypokalemia, infection, electrolyte disturbance, constipation, drugs, dehydration, trauma. In your ward, in our medicine ward, you will find so many patients of CLD having this kind of hepatic encephalopathy. So we have to manage it very meticulously. Without meticulous management, the patient will not survive. Signs of flapping tremor, constructional apraxia, hyperreflexia, and bilateral plantar extensor. Look, a patient come to you with CLD. When your system examination, he found the flapping tremor, constructional apraxia, and hyperreflexia, and bilateral plantar extensor, there will be diagnosis of a hepatic encephalopathy. Classification: no need to know that. Treatment: intubation. Nasogastric tube permits the safe administration of nutrients and medication. Lactulose, lactitol, rifaximin, zinc supplementation, and liver transplantation. And you have to know the management of this in your long case, or in your, when we will manage the patient, we will find this kind of patient, so many patients. So you have to manage it very meticulously. Even examiner will ask you how lactulose functions and what are the other drug if you can apply in case of hepatic encephalopathy. Then you have to say name of lactitol, lactulose, rifaximin, zinc supplementation, and at the last of all, liver transplantation can be performed if indicated. Hepatocellular carcinoma is one of the complications of liver cirrhosis. No need to know this. Portopulmonary hypertension, hepatopulmonary syndrome. You should know the term of this. Hepatorenal syndrome. All of these are complications of CLD. Malnutrition in cirrhosis. No need to know that just bone disease can occur in chronic liver disease. Hematological neutropenia and thrombocytopenia is very much important because in case of neutropenia there will be frequent bacterial infections. In case of thrombocytopenia there will be development of bleeding tendency or even stroke may occur. Thank you. So, a patient 52-year male, anorexia, abdominal swelling for 2 months, vomiting of blood, and passage of blood tire stool for 2 days, and unconscious for 4 hours. What may be your differential diagnosis? Number one diagnosis may be chronic liver disease. Another diagnosis may be intra-abdominal malignancy. And in case of only abdominal distension, a patient come to you, what may be the other differential diagnosis? That may be disseminated tuberculosis, nephrotic syndrome, intra-abdominal malignancy, and CLD. Look, why there is vomiting of blood? Because gastroesophageal complication, gastroesophageal varices. Why passage of blood tire stool? One of the causes is gastroesophageal varices and another cause is coagulopathy. Why the patient is unconscious? Due to the accumulation of neurotoxin in the body and development of hepatic encephalopathy. So definitely this may be a case of chronic liver disease. If you examine, we will find GCS 12 by 15, anemic. Why anemia? Because due to the deficiency of hematinics. Why icteric liver is not able to produce bile, and why ascites? Due to the lesser absence synthesis of albumin and presence of collateral vessels of anterior wall and along with stigmata of chronic liver disease like spider nevi, leukonaki, and gynecomastia, inflating tumor. This clinical scenario supporting this kind of uh, positive finding of clinical examination, we can think that this may be a case of chronic liver disease. So dear student, whenever you will find this kind of clinical scenario in your board examination or in your OSP examination or written examination, you should first formulate some differential diagnosis on the and after that make a final clinical diagnosis on the basis of clinical scenario. I think whenever you will face a problem regarding chronic liver disease, you will be able to answer all of the question. Hope that in your next class we will discuss about a new topic. Till then, take care, stay safe, stay connected, stay with your books and stay with our live classes. Thank you very much.